Welcome everyone to today's webinar, Rethink Your Hospital Revenue Process, Reduce Rejected and Denied Claims, and Improve the Patient Experience. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. First, we will begin today's webinar with a presentation and have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into that Q&A box you see on your screen. Today's session is being recorded and will be made available after the event. You can use the same link used to log into today's webinar to access that recording. And finally, if at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into that Q&A box. We are here to help. With that, I am pleased to welcome today's speakers. David Emerson is the Vice President of Strategy and Business Development for Cardinal Health. Dave currently serves as the Vice President of Strategy and Business Development with Cardinal Health's pharmaceutical distribution business. He joined Cardinal Health in 2005 after starting his career with MedStar Health, working in the hospital environment. Since 2005, he has held various leadership roles across Cardinal Health in nuclear pharmacy services, medical supply distribution, medical products, and now pharmaceutical solutions. Laura McIntyre-Hansel is Reimbursement Solution Director for Cardinal Health. Laura has over 25 years experience in the healthcare industry, including 18 in specialty healthcare insurance reimbursement. She's a clinical expert with experience in nursing, pharmacy, coding, billing, and patient assistance. She began her career with Central Care Cancer Center as a nurse, where she became interested in and passionate about achieving expedited claim processing to support a better patient experience. She then transitioned to Central Care's Financial Counseling Department and developed the system's reimbursement program for 14 sites of care. Later, she took on a similar role for Premier Specialty Network, the largest rheumatology network in the U.S., where she developed a remittance process for 70 facilities and 140 providers. David and Laura, thank you for being here today. David, I will now turn the floor over to you.
Great. Well, thank you, Molly, and thank you, everybody, for joining us this afternoon. In the last couple of months, we've seen a lot of interest in this topic from the Becker's community, and we couldn't be more excited to have this discussion with all of you today. Whenever you consider any areas within your organization to make improvements, obviously it's always best to start by making sure you fully understand the situation and the current state. So what we're going to do is over the next couple slides, we're just going to take a moment to do just that. Across our industry, there's a general belief that denied or rejected claims to a certain point are an unpredictable and maybe even an unavoidable part of providing health care. And industry research shows that on average, nearly 10% of all claims are rejected or denied. And we've seen that number as high as 20% in some cases. And what this does is it translates to an average loss of up to $5 million every year for most hospitals. And industry research also says that about 2/3 of these rejected and denied claims are recoverable, and that only about 1/3 of providers are appealing denials. So let's talk a little bit around what is causing these denied claims. So a recent industry study revealed that CEOs tend to categorize claims issues into 4 categories: coding errors, medical necessity issues, clinical validation denials, and front-end issues which typically involve patient-facing aspects, such as not asking all the right questions at the time of admission. However, what most people don't realize is that there are triggers for rejected and denied claims. Those are simply the tip of the iceberg, and that there's many other factors that play a role, and understanding these is an important step in improving these processes. So as you heard, co-presenting with me today is my colleague, Laura McIntyre-Hansel. She has a unique perspective in understanding this status quo. And there's many stakeholders involved in these processes, and Laura has personally been in a number of their shoes. So I'm going to now turn it over to Laura so that she can share her story and put her journey to talk about a workable, sustainable solution. So Laura?
Thanks, Dave. Hello, and once again, welcome. Like you said, my name is Laura McIntyre-Hansel, and I'm a nurse by training. Disease treatment is challenging, and it's a confusing path at best of times, definitely for the patient, but for the facility as well. We all have those moments in time and events that in hindsight are milestones or defining points in our life. I'm no different. As a nurse, I was focused on doing all I could for my patients. But in my late 20s, I found myself on the other end of that stethoscope. I was the one receiving the diagnosis. And although my path was ultimately successful and much easier than some, it opened my eyes to the minefield of challenges that are faced by our patients. I was working in a busy cancer infusion center, and it showed me that our system overall in healthcare is fractured. It allows for a myriad of inconsistencies and also causing financial challenges to the facility. It became my passion to make a better mousetrap. And although my nursing history was great, I quickly found that I lacked knowledge in many other areas, but coding and billing. So back for more training I went. I've spent the better part of the last 2 decades developing and honing practices that remove these inefficiencies, as well as allow for transparencies in the healthcare remit process. So to begin to rethink a solution, we really have to first step back and recognize and understand what these causes are. And further know that what we see, as Dave said, on the surface is truly just the tip of the iceberg. Things like rapidly changing step therapies, shifts in site to care requirements, medical necessity versus medical coding policy. It often seems a lot like hitting the shooting target at the county fair. Delays and barriers in the coding query process, and not to mention many players and hands in each service that pass through on its way to submission. Each of these can result in a barrier to payment, and these just highlight a few. And like the iceberg, what we see on the surface doesn't begin to reflect the scope of the problem underneath. Studies report that 90% of errors are avoidable, but the reality of the situation indicates that once the error has occurred, it's much harder to correct. Advisory board research shows that whereas nearly all denials are preventable, only about 66% are recoverable. Facilities have numerous staff hours wrapped up in back-end processes and practices pursuing these corrections. I just said that 66% of denials are recoverable, but also 35% of providers are appealing those denials. Maybe it's because reworking denials and rejected claims is hugely labor-intensive. Or maybe it's the fact that it's a multi-step process that overextends the resources that the facility has at hand. But studies state that this is amassing an $8.6 billion in additional administrative costs. In the illustration in the case study, we see a lot of the implications here in action. We have a 47-year-old patient with a diagnosis of rheumatoid arthritis, and they're ordered to receive Remicade. The facility does the pre-screen, verified coverage, and it was notified by the payer that prior authorization wasn't required because it's on formulary. Great. We're good to go. We've done our due diligence. The patient receives initiated treatment and returns for scheduled ongoing treatment. Well, RevCycle receives an initial denial. It resubmits with notes indicated that, hey, we did our pre-screening and no prior auth. All of this time, and now we're at 90 days past. The initial infusion in the patient has just completed their 3rd infusion. We receive a denial. It's upheld by the payer. It's citing that the facility didn't have the right to buy and bill, and that the insurance has guidelines indicating that the medication has to be obtained through PBM and a third-party pharmacy. The patient's going to have the same outcome to each of the 3 infusions that was been completed to date. So the facility quickly adjusts, and now they're receiving the medication through the required payer. But it's not able to submit and receive payment for the first 3 infusions. This is just one of those 33% of errors that are preventable, but once they've happened, they're not recoverable. It's impactful to the facility's bottom line, overcoming losses in revenue like this.
Laura, what about, everybody's thinking about biosimilar drugs right now. So what if a hospital had subbed this Remicade for Inflectra? Would the impact be different?
Well, the impact could be worse. Many payers have formularies and preferred medications, and this is highlighted in the biosimilar world. It's often difficult for a facility to know which one can be used successfully and with what plan. To further complicate the issue, in the biosimilar medications are subject to the same prior authorization process and approval, but they're not able to be substituted for each other or for their name brand compatriots. So to answer your question, Dave, Biosimilars with their unique remit challenges potentially can add even an additional hurdle to this. So let's dive a bit deeper into this breakdown. As we're in the midst of the Summer Olympics, it's kind of fitting to leverage the example of a track and field relay race. I was speaking earlier about the players that hand each of these service pass-through on their way to a submission. But in this case, our race begins with a provider or clinician who actually writes the service order. And it hands the baton to the prescribing or pre-screening services. So pre-screening hands it off to scheduling, scheduling hands it off to pharmacy, pharmacy hands it to infusion, up to billing and coding. Each one of these handoff points represents an opportunity to stumble or to create an all-out drop in the claim submission cycle. Further, each of these players impacts the nature and the success of the service claim. And if this claim is reoccurring, it affects each and every one to come, often without even realizing the impact that their decision has on the service claim overall. Even a minor stumble can cause significant payment delays. And all-out drops, well, they're denials and losses. Rejected claims require one-off handling and often have to be addressed 5 to 7 times before a submission can come off successfully. At $181 in additional administrative costs per touch, that definitely supports the reported $8.6 billion in additional administrative costs.
Yeah, Laura, what if I'm a facility that has staff and I have processes in place to perform pre-screening and other related tasks? Would this apply to me?
Well, definitely still would apply to you. In many cases, the portions of the review provided prior to service isn't as complete or in-depth as the reality of today's healthcare world requires. A misstep or a lack of full understanding can and does cause less than optimal outcomes, just as reflected in our Remicade case study. So current studies show high out-of-pocket costs actually keep patients from accessing care. And research is showing that a relationship between increasing patient cost burden and healthcare service utilization. This is suggesting that when patients pay more for their healthcare, they're less likely to access treatment. Losing patients in the care continuum has far outreaching impacts, including the loss of revenue-generated ancillary services that often accompany most care. But on the other side, patient unpaid balance is equally financially impactful. 60, 90, and 120-day billing, up to and including write-off to collections, which even in paid only get pennies on the dollar. And with drug margins as low as they are, facilities must make every attempt to account for these losses. In the illustration of the case study here, it's very impactful. A 48-year-old male treated with Zolar for a diagnosis of asthma. The pre-screening was completed and treatment was initiated. Initial denial was received due to lack of medical necessity on the diagnosis. The facility made the correction and rebilling was submitted. During this time, the patient continues the course of treatment because it's helping. It's helping resolve and manage his asthma. The claim is successfully paid by the payer, but it leaves the patient his remaining deductible and out-of-pocket percentage per the terms of his coverage. But to further complicate the issue, the patient plan rolls shortly after the initiation of treatment. So not just one, but 2 are left to fulfill the New Year's deductible and out-of-pocket. Now, the patient in this case made payment arrangements, but life happened. The patient ended up defaulting on his payment agreement, and the amount is ultimately written off to bad debt. 60% of non-paid patient balance on discharge is ultimately written off to bad debt. That's a staggering statistic.
So, Laura, tell me about the facility side of the scenario. Are there hospital benefits to this?
Well, there really are. I mean, there's steps that can be taken and opportunities leveraged to affect a much different outcome in many of these cases. We'll use this illustration for example. The patient could have received a commercial copay card by the drug maker that would have offset the majority, if not all, of the patient responsibility for cost of drugs. So the benefit to the facility in this case is clear. Payment in full versus write-off to bad debt. But further than that, the patient experience is a common healthcare buzzword. And I have to tell you, few things impact the experience a patient has, both positive and negative, than when it involves a patient's checkbook. So there's a different way to look at these issues, one that garners a much different result. Reimagining this process and focusing on a proactive and a holistic approach. And what I mean by proactively addressing all of these pain points is planning for their outcomes instead of reacting to it in post-service. Decreasing the sheer number of rejections and denials seen on a daily and somewhat hourly basis. It goes a long way to reducing that massive dollar amount for administrative burden that has recently become crippling. Again, proactively identifying these patients, situations, and indications that can benefit from these industry programs, either to stretch the facility's charity dollar further or to prevent additional losses and write-offs, or if nothing more than providing enrichment to the patient experience. Adopting a proactive approach and using a process-to-product model helps to achieve up to an 80% reduction in rejected and denied claims. This in itself is hugely impactful to a facility. Every day in healthcare, we support and celebrate our doctors and nurses as heroes that they are. Revenue cycle deserves the same celebration and support. A proactive process-to-product application enables them to be set up for that success. Cardinal Healthcare Reimbursement Solutions offers one of the very few proactive process-to-product reimbursement solutions found in the marketplace today, providing a solution that addresses these industry problems and allows for optimizations that are immediately impactful financially. When we look at workflow efficiency, less rejection and denial means quicker claim submission, increased number of clean claims, less time spent on coding queries and claim rebilling. It allows revenue cycle staff to optimize output and return. And the decrease of bad debt by identifying the roadblocks to the remit process before they occur. Identifying assistant programs to enhance the patient experience, as well as reduce facility-held patient balance. Identify and avoid unforeseen payer denials for plan exclusions, as well as site-to-care shifts. Under the support care admission, I became a nurse to help people. The ability to support a facility in its care mission and enable it to provide the best care to its community as possible, and to decrease the patient's financial burden in all available cases. Cardinal Health Reimbursement Solution enhances that relay handoff between our stakeholders, and it allows for that process across the continuum, allowing for full transparency at all stages and at the claim of the service. It supports and complements the on-site programs and staff.
Yeah, great. Thank you, Laura. So Laura just shared with us another way to approach the revenue cycle. And earlier in this presentation, we mentioned some of the industry averages on a few of the ways that the status quo is really taking a toll on health systems. So I'm sure at least some of you are wondering what would be the opportunity for improvement in my own facility. So we're going to share with you just a few snapshots to show you what we've recently seen.
So in this illustration, we're looking at a health system opportunity. This was a medium-sized health system that had 4 hospitals. During our analysis, we identified $5.8 to $6.2 million at risk in one location. By putting together and implementing the proactive comprehensive analysis, it uncovered patient assistance support, providing $1.4 million in added revenue on top of that. So we're looking at a 6-to-1 ROI with a proactive model. The opportunity here will continue to increase as multiple infusion clinics are brought in line.
So Laura, is this an opportunity for the system, for multiple areas of one hospital, or solely for one infusion clinic?
Well, what we're seeing here reflects the opportunity found in a single one of their 4 sites. As site 2, 3, and 4 were brought on, this would be exponentially increased. So looking at the other end of the spectrum in rural hospital and community owned, this illustrates a 40-bed community hospital. And we identified during the analysis 923,000 to 1 million annually at risk. And through the proactive comprehensive implementation, 5-to-1 ROI with the proactive model was identified. This increases the facility's cash flow and supports for on-site teams, which is critical.
Laura, how about, does it matter if the hospital participates in 340B?
No, it doesn't. That's a completely different program and has no relationship to what we're looking. Both 340B and non-340B are equally as impacted and beneficial in this process. So to begin to apply the reimagined process to your facility, begin by evaluating your current processes. Look for inefficiencies, lack of transparency. Secondly, consider your stakeholders, your silo, how your organization is put together. Evaluate your areas that you could apply optimization. And finally, assess your facility's capabilities. Look at the support that you would need to attain your goals and what goals are truly attainable for you. An important component, it's not to be underestimated, is the support and involvement needed by your facility's teams to make these type of improvements. Remember the relay race. Every one of those areas will need to participate in aligning on how you will do things differently. It's not an initiative that can take place in the scope of a single department or with a single leader. It truly is multidisciplinary effort that requires buy-in of senior leadership and support on this level to change, well, how the management of it goes. Otherwise, your process will be fraught with breakdowns, errors, and in turn, it'll limit your results. Oftentimes, the manpower needed is significant, and no change happens overnight, but the result is most definitely a better path forward.
Great. Now, thanks, Laura. Molly, why don't I turn it back over to you, and we'll go try to answer some of these questions from the audience in the chat box.
That sounds great, Dave. Thank you. And thanks, Laura, for that great presentation. Attendees, like Dave said, we will now begin today's question and answer session. You can submit any questions you have by typing them into the Q&A box you see on your webinar console. Let's get started with the first question. Laura, this one is for you. What is a good denial rate? What if my denial rate is only 8%? Is there still an ROI for my hospital?
Well, I mean, a good denial rate is 0, but that's, not a reality in our world. But the national average is around 10% of initial rejection and denial. Now, I will say all facilities have back-end practices that look at these rejection and denials to correct as many as possible. But all of this comes at a price for the facility in the form of man hours and wages and delayed submission of claims. So if a facility sits at a claim denial rate of 8%, most definitely there's still benefit in this.
Okay, terrific, Laura. So like you said, ideal rate, of course, is 0, but that's not realistic. Still ROI to be gained if it is only 8%. Let's turn to our next question. David, I'll tee this one up for you first. If we already use a vendor software to address part of the process, do we need to do anything more? And if so, is this approach complementary to other vendor software?
Yeah, thanks, Molly. Thanks, whoever asked that. Good question, good call out. I think the key takeaway to remember is that the software and technology used today really only hits on and addresses a small fragment of the causes that result in these rejected and denied claims. So yes, there's a lot more that we need to do. And if health systems, if you're going to rely solely on software tools, you're never going to see that type of ROI that we were showing earlier in the presentation. As far as compatibility with other systems, I'm going to push that one over to Laura, who's a little bit more on the technical expertise side. Laura?
Absolutely. Thanks, Dave. Definitely, it will companion with things that you already have on site. One of the beauties of this program is that since it doesn't require an IT interface and that it is a service, is that we're able to take what's currently on site at a facility and provide the companion tools and provide that service to make it a holistic approach. So if you're currently using a software that does part of this or does a bit of this or provides some assistance, definitely, we help bridge that gap.
Thank you both. Our next question is for the both of you. I'll open it up to either to take the first stab at, and then we can open up to your co-panelist. This attendee would like a bit of clarification. Is this a service that Cardinal would take over? Is this a training, access to a tool? Can you clarify a bit more about what exactly Cardinal is proposing here?
I can definitely.
Yeah, take that one, Laura.
Thanks, Laura.
Okay. This is a service that Cardinal offers. It isn't training. Cardinal does not take over. What we do is that we go in and plug in and evaluate on a pre-service level, helping to screen and facilitate that proactive process to product nature. And then it really provides that roadmap to the claim for the facility. So when their revenue cycle comes in, it has everything has been pre-reviewed and has all the benefits needed to optimize claim submission. Amanda, I hope that answers your question.
Thank you, Laura. Another question came in from an attendee saying, you mentioned that 32 is coding errors. Do you think that by adopting coding, AI would help the coding denials? Laura, do you have any
I can keep that one.
Would you like to go there?
Oh.
Yeah, I'll start off real quick. Artificial intelligence is something that we spend a lot of time looking at in the marketplace, and Laura and I have spent a significant amount of time discussing it even recently. So I'll just sort of tee you up, Laura, for your thoughts.
Mm-hmm. Well, as far as AI in healthcare, I think there are certain things that AI is wonderfully attuned for, and I think there's certain aspects in healthcare that AI will be applicable for. But healthcare, in its basis, is a practice and an art. You know, we're never going to be able to have AI predict what our doctor is going to code to the highest level of specificity that's required. That will always be our doctor's job. You know, AI can definitely help when it comes to the facilitation of how certain payers pay things or what their requirements are. But when it comes down to it, you know, our doctor still needs to be our doctor, and our healthcare will be that. I hope that answers the question.
Thank you, Laura. Let's see. Another question. How are you proposing, or what precise steps would you suggest organizations take to prevent site of care shift?
I'll go ahead and answer that one, Dave. Site of care shift is a very difficult and tricky water to maneuver. As we continue to go on, we see more and more of this. There are steps that can be taken to begin to combat that, but when it comes to an insurance payer model, especially those that are self-funded, you know, when they say a site to care shift is required, you can't get around that. You know, I mean, that is what they deem. The key in what our solution is proposing is to be able to know ahead of time when those site to care shifts are impactful to your revenue cycle, so that you don't get 3 to 4 infusions in and realize that you have loss that's unrecoverable before you know that that's going to be an issue.
Thank you, Laura. Laura and Dave, thank you for this really wonderful presentation and addressing attendees' questions. Attendees, if there were questions that the panelists were not able to address, they will be following up, and here is the contact information if you'd like to follow up yourself. With that, Dave and Laura, let me invite the two of you to share your final thoughts today. Dave, we'll start with you.
Okay. No, I just wanted to thank everybody for the time and understand that this might be a bit of a departure from the way that you might be thinking about things today. I thought the questions were very insightful. But certainly, again, reach out to the email address or the website if you have any questions, and we look forward to being in touch. Laura?
I wanted to thank you all for taking the time to attend today's presentation. And I know that we all think that these inefficiencies and coding problems are just part of our daily life in the revenue cycle in healthcare. But I'm here to tell you for the last 20 years, there is another way to look at it. There is a better mousetrap out there. And there are ways to make things more impactful and more efficient. And I would look forward to being able to talk to you about those.
David, Laura, thank you for an excellent presentation, and thank you to Cardinal Health for sponsoring today's webinar. To learn more about the content that was presented today, please check out the resources section on your webinar console and fill out that post-webinar survey. And on behalf of Becker's Healthcare, thank you